Here to talk about nutrition and the role of supplements in IBD, another member of the IBD team at Seattle Children's, Dr. Dale Lee. Please join me in welcoming Dr. Lee.
Thank you all for joining us here for our IBD Education Day. So it's my privilege to talk about the role of nutrition in inflammatory bowel disease. You guys heard from Dr. Suskin before, and I will tell you right now, the mainstay of IBD therapy, sort of nationally and recognized, is using medications, but we feel strongly that nutrition has an important role for inflammatory bowel disease therapy as well, be it as a primary therapy or as something adjunctive. So the objectives of my talk are, first, we're going to review the role of location of disease. Second, we're going to discuss common misconceptions about diet in IBD, and I will ask for a little bit of audience participation for that section. We're going to review what a low residue diet is, what a high fat diet is, and if there's any role for utilizing these therapies. And then finally, we're going to discuss special dietary therapies. We're going to focus on exclusive enteral nutrition, which is a formula-based diet, and also the specific carbohydrate diet, which many of you are probably familiar with. So to briefly review, you guys have heard about this already. Inflammatory bowel disease, it's a chronic medical condition. It can affect any portion of the GI tract. And we're going to be talking a little bit about location here. The two types of IBD, Crohn's and ulcerative colitis. Can I get a sense from the crowd, family member with Crohn's disease? And then family member with ulcerative colitis. Okay, great. So there's a good distribution of both here. And I'll tell you all, in terms of therapies, there's a lot of overlap, but there are some nuances about how location or type of disease impacts which form of therapy we would recommend. So to briefly review the underlying cause of inflammatory bowel disease, and in my opinion, this is important when you talk about why do we even think about using diet as therapy. So for inflammatory bowel disease, this arises in the setting of having a genetic predisposition. So your immune system is primed to function in a certain way. There is an environmental effect as well too. So we know that being exposed to antibiotics early on has a potential effect on inflammatory bowel disease risk of development. And we also know that the foods that you eat, we also think that the level of cleanliness in our environment plays a role as well. In the setting of a genetic predisposition, environmental exposures, there is an immunological response, as you guys know, and this is sort of a brisk, ongoing inflammatory process. So the risk of developing inflammatory bowel disease, we know that the incidence of IBD in the world is rising. It typically occurs first in more industrialized countries. We know that early life exposures play a role, and I discussed sort of antibiotics, certain foods. And then finally, dietary factors, and we're going to go into this a little bit more in detail. So certain dietary factors that we know are associated with disease risk. So on the left hand, those are risk factors. So we think that saturated fat in greater quantities is a risk factor. Total polyunsaturated fatty acids, omega-6 polyunsaturated fatty acids in particular, and also the amount of meat consumption. We think that red meat is probably a little greater risk. In terms of protective factors, we think that fiber, fruit, and vegetables in general all are protective. Again, these are very, very large database studies, so I am not saying that for you and your child that consuming any one food is going to put them at risk or eating one food is going to be completely protective, but looking across broad swaths of population, these are the signals of dietary risk that we've been able to identify. So I thought I'd be funny. We're supposed to talk about location of disease, but I'd say location in the world I think is important for us to understand risk as well. So in red are areas of the world that are higher risk for developing inflammatory bowel disease. So if you live in the areas highlighted in red, you are at greater risk. And this is a map from 1995, so things have actually changed now. It's been almost 20, 30 years since then. Now, for example, China, North and South Korea, Japan, Australia, these other countries are also showing increased risks, so they would be red now as well. And if you think about these are the more highly developed countries, more industrialized countries. So we're going to talk about location of disease in the GI tract. So as you all are quite familiar, we'll do a quick review here. Crohn's disease can affect any portion of the GI tract, all the way from your mouth down to the anus. Ulcerative colitis is different in that it is isolated to the colon only. In terms of medical therapies, if you have Crohn's or ulcerative colitis, in general, medical therapies are quite similar. Okay? If you're thinking about using a nutritional therapy, the location of disease may play a slightly greater role in deciding which nutritional therapy is the best one for you. And we'll go into details of this. So briefly, how can location of disease explain symptoms? So if you have ulcerative colitis, you potentially have inflammation in your colon, and we hope that the inflammation is now under better control. But if you have inflammation in the colon, this can cause frequent loose bloody stools. It can cause what we describe as nocturnal stooling or nighttime stooling. And this occurs if there's inflammation in the colon, which is your reservoir for holding stool. You're frequently going to have much more frequent stooling. For Crohn's disease, as I mentioned before, you can have inflammation from mouth to anus. So this whole list here is a list of different symptoms that your child could potentially present with, from oral ulcerations to abdominal pain as soon as you eat, to bloating and a gurgly sensation in the small intestine, the same colitic symptoms that I described for UC. And unique to Crohn's disease is perianal inflammation. So this is right around the exit of stool from your body. You can have inflammation there resulting in skin tags. You can have inflammation resulting in small focuses of infection as well too. And at times this can cause pain with sitting. So location of disease. We're going to talk a little bit about nutritional therapies here. So I'm not going to go into detail about EEN here. That'll be a few slides later. But in the discussion about location, I want to hit on how does location affect nutritional therapy efficacy. So again, EEN is a complete formula-based diet where you don't eat food and you consume only formula. So is EEN effective for both ulcerative colitis and Crohn's disease? We have actually found that EEN does not seem to work well with ulcerative colitis. Also, if you have Crohn's disease affecting only your colon, EEN seems to be less effective as well too. So if your child has Crohn's, we have found from studies that if they have small bowel involvement, so ileal or ileocolonic, we think that the best response is if you have some degree of small bowel inflammation, and less so if it's just colonic inflammation. So again, the conclusion here is the data suggests that this EEN formula-based approach is effective, most effective if you have small bowel or small bowel plus colonic Crohn's disease. What about the specific carbohydrate diet? So our studies have shown that the specific carbohydrate diet, which I'll go into detail again later, is effective for both ulcerative colitis and Crohn's disease. So the specific carbohydrate diet, briefly, is a whole food-based restriction diet. And this is different than EEN because you can use it for ulcerative colitis as well. So Nurse Teresa, who put together the conference, asked me to talk about some common misconceptions about diet and inflammatory bowel disease. So I have a list of 7 things that I've listed as myths, but I'm going to tell you right now, not all of them are myths. So I'm going to ask you guys to vote, is this a true myth or is this not a myth? Okay? So, myth number 1, a low-fiber diet is good for my inflammatory bowel disease. I'm going to ask that the audience not at all be critical of anybody else who answers, but I'm going to ask for full participation. Who thinks that this is a truth? Okay. Who thinks that this is a myth? Okay, we'll talk about this. So, Crohn's disease has been found. So if you have higher dietary fiber intake, studies have shown that you have a 40% lower risk of developing Crohn's disease. There's a big prospective following over time study called the Harvard Nurses Health Study. And from this study, they have found that individuals that consume greater dietary fiber are less likely to develop Crohn's disease. We as clinicians, as physicians, will extrapolate this to say we think that a higher fiber diet is probably beneficial to help minimize risk of disease flare as well. The study from Harvard showed that the greatest risk reduction for adults was if there was greater consumption of fiber from fruit. So again, not all fiber is created equally, is what this study suggests. I'll give one caveat here, guys. I'm going to talk about studies. hanging your hat on a single study is not enough, so we have to take into context sort of the body of different studies that have been done, but I will highlight a few specific studies right now. For ulcerative colitis, there's not as strong of a protective effect with fiber, but studies have shown there is no worse inflammation with the consumption of fiber, okay? I'm going to talk a little bit about short-chain fatty acids as well, and fiber is beneficial for the production of these. So what exactly is fiber? We all kind of have an idea of what fiber is, fruits, vegetables, whole grains, but the formal definition is it is the edible part of plants and carbohydrates, and they are resistant to digestion and absorption in the intestine, so they kind of pass through you, okay? There are a couple types of fiber that I want to highlight here, soluble fiber and insoluble fiber. So the difference is soluble fiber is a fiber that will dissolve in water, and it becomes a gel-like substance when it's in your intestines, and it slows down the speed of transit through the GI tract, okay? Insoluble, examples of these are the fiber from oats, nuts, seeds, beans, lentils, and certain fruits, vegetables. Insoluble fiber is different. It is not dissolvable in water. So for example, if you chew a big piece of kale or of lettuce, this is insoluble fiber. What this does is it increases the volume of the stool, and it can actually help to speed the transit time. If your child is constipated, for example, sometimes we'll say, increase the amount of fiber you eat so that things can transit through more readily. Examples of insoluble fiber include wheat bran, certain vegetables like kale and lettuce, like I mentioned, and certain whole grains. So, fiber is metabolized by bacteria to become short-chain fatty acids. In this diagram here, the left side is the inside of the GI tract, so it's the gut lumen, or the inside of your intestine. Fiber goes on through the GI tract. Like I mentioned before, it is not digested by the body, it is not absorbed by the body. What happens is the bacteria in the colon will munch on the fiber, and they will produce certain things called short-chain fatty acids, acetate, butyrate, propionate. You don't have to know that, but the take-home message is when the bacteria munch on the fiber, they produce beneficial substances that nourish the intestinal epithelium, okay? So again, fiber is beneficial for this reason. So for myth number one, this is actually a true myth, okay? Fiber is actually beneficial for you. One caveat, fiber can make your symptoms a little bit worse. So for example, if you eat a lot of insoluble fiber, you may have increased diarrhea, but in general, that's a symptom, that's not inflammation. So we'd love for you to continue to consume fiber if possible. All right, myth number two, when in an IBD flare, I or my child needs to be on a low residue diet. True? False? Myth? Not sure? Okay, all right, okay.
What's a low residue diet?
Good question. Low residue diet. So this is a diet that limits high fiber foods such as whole grain, breads, cereals, nuts, seeds, raw fruits, and vegetables, okay? So sometimes people will describe the BRAT diet, so bread, rice, applesauce, and like tea. So this is thought to be a diet that is high in refined carbohydrates like white bread, white rice, pasta, refined cereals, clear juices, canned, cooked fruits and vegetables. This is actually a bit of a myth here, guys. So if you have an IBD flare, sometimes you do need to gravitate towards certain foods that are just more comfortable. Studies have demonstrated that people sometimes will migrate towards bananas and rice and yogurt because they feel like it makes you feel better. But this is not an absolute. Some people say, I'm in an IBD flare, I have to be on a low residue diet. It's not a definite, but if you feel that it helps your symptoms, that's okay. But remember, it's helping your symptoms. This is not impacting the inflammation, okay? So this is a myth. So, no, you don't have to. Fiber is an important part of GI tract health. Though certain raw fruits and vegetables can worsen symptoms, they do not worsen inflammation. And we do want you to consume fiber when you do have a disease flare. I mentioned fiber are consumed by the bacteria in your colon, and they help to nourish the GI tract, okay? So this is a good thing. All right, myth number 3. I cannot eat any nuts or seeds with IBD. Truth? Myth? Not sure. Good job, guys. So this is a picture here. So this is an example of the small intestine, okay? So we'll say this is the ileum. I'm talking about the picture on the left. You can see that there's an area described as a stricture. What a stricture is it's an area of scarred down tissue from long-standing inflammation. One of our goals is to try to prevent the development of a stricture. So if we control the inflammation, we don't allow it to persist. The goal is to prevent this narrowing. If you do develop a narrowing or your child develops a narrowing, as you can see, it's going to be hard for stuff to pass through there. So some kids will say, I feel full very quickly, or I feel this tremendous gurgly sensation whenever I eat things. That's because stuff is squirting right through that narrowing there. You can imagine if there's a big hunk of something that gets stuck right there, you're going to be in trouble and you're going to have some vomiting, severe abdominal pain. All right, in IBD foods, foods that can cause a blockage in a narrowed area of intestine should be avoided. So we will oftentimes say, please avoid things like popcorn, because the big hull of popcorn can potentially get stuck. We'll say, please avoid things like gigantic sunflower seeds. Don't swallow sunflower seeds whole. We'll say, please be careful about eating a big hunk of raw carrot. My general rule of thumb for families is if there's a concern that there might be narrowing, please avoid eating things that are large and chunky that do not dissolve in a cup of water over 24 hours. For example, you put a big hunk of carrot in a cup of water, it's going to stay there. So either you have to chew it carefully, you have to cook it, or you have to make sure that you provide it in a little bit more cut up form of shape for the kids. But in general, you should talk with your GI doctor about, am I at risk of having a stricture or narrowing? How significantly limited from these things do I need to be? So if I tell my patients, if I don't think they have a stricture, please do eat things like raw carrots. Those are good, those are healthy. But if I'm at all worried, I'll say we need to be extra careful. If you have any symptoms, you need to chew more carefully. And for younger children, I'll ask parents to thinly slice it or to cut it up in smaller pieces or cook it. So I had a wonderful family talk to me recently, and they were telling me this was an all-star father. Because he had heard no seeds, no nuts, he was picking out each individual seed on a strawberry for his child. And it touched my heart. I was like, wow, that's amazing. I couldn't do that for my own kid. But you don't have to do that. You don't have to do that. So, and again, nut butters and nut-related flours are totally fine. We're thinking about mechanical obstruction here, okay, guys? Myth number 4. Diet is not important if I am taking immunosuppressive medications. And I've listed some immunosuppressive medications. Diet is not important if I am taking immunosuppressive medications. True. False. Not quite certain. Okay, you guys are right on here, okay? I think you guys have probably heard the spiel from your GI doctors, your nurses, and the dietitians here, okay? Again, I've highlighted this little diagram here. Environment, food, bacteria, this plays an important role here. It doesn't matter if you suppress the immune system. We always say there is the role of food because it can cause ongoing inflammation, or it can be a trigger for sort of ongoing sort of cycles of inflammation. So let's treat both the potential causes with diet, and let's also appropriately address the immune system with medications when needed as well too. And Dr. Susskind went in detail over all the meds. Is that correct, guys? Great. So first, diet plays a broad role in everybody's health. You can have IBD, you cannot have IBD. It is important for everybody. The bacteria in your GI tract, there are trillions of them. They are impacted by the food you eat, okay? In inflammatory bowel disease, where you potentially have ongoing inflammation in the intestines, diet's even more important. So we would say it's important to be mindful about your diet. And this is going to be a discussion with your GI doctor, your nurse, and the dietitian about how rigorous do I need to be about diet. But I think a fair rule of thumb that I feel very comfortable saying in a group to everybody is, please be thoughtful about the amount of highly processed food that your child consumes. Again, I'd say this to just a general pediatric kid walking down the street, in particular with inflammatory bowel disease, important to be mindful of these things. Does that mean they should never eat a flaming hot Cheeto? No. They can have that on occasion, but be mindful about the amount and frequency of things like that. Another important point. So in the past, people thought, I'm going to try to use nutritional therapy or medicinal therapy. we have learned that these can kind of go right alongside each other really nicely, okay? They can be complementary together. So if your child's on medication, it's very appropriate to think about how can diet be a part of this. All right, myth number 5. Dietary therapy for IBD can help anyone avoid medications. Truth. Myth. Not quite sure. Okay, good. I appreciate the honesty, guys. So this is an important point here. If you guys watch the news, if you guys hear about this sort of web stuff about Seattle Children's Hospital, there's a lot of talk about dietary therapy. And I think it's awesome that we're having the discussion. But importantly, dietary therapy alone does not work for everyone. So I will see patients in clinic and families and they say, I do not want these medications, I'm gonna use diet. And I say, I'm happy to help support you guys in integrating nutrition into your therapy, but to be completely honest, it does not work for everybody. So you have to be careful here, okay? From my perspective, from the doctor's perspective, very important to follow objective parameters of change and improvement, okay? So your medical team, your doctor should be following things like labs, stool calprotectin. There may be repeat endoscopies. There may be endoscopies that are repeated as well. And again, the goal, if you're using nutritional therapy, you have to see that these objective parameters are improving. Some people will say, I feel so much better. But they come to me and I see that their CRP is sky high. Their fecal calprotectin is sky high. Then I'd say, I'm really glad your symptoms are better, but unfortunately, this dietary therapy is not appropriately controlling inflammation, so we have to discuss adding on medications, okay? So this is indeed a myth. Dietary therapy does not work for everybody, but we are happy to engage you and your families and your children with discussing what is the role of dietary therapy for you. I'll go into more specifics in a bit. All right, myth number 6. Myth number 6. A high-fat diet is harmful for patients with Crohn's or ulcerative colitis. Truth. Okay. Myth. Not quite certain. Good. All right. So this is a good discussion point, guys. I think we have a lot of different thoughts about this. So it's a balance here. So I want to talk briefly about different types of fat and then come to a conclusion about myth, truth, or is the jury out on this. So different types of fat. So unsaturated fat is fats that are liquids at room temperature. These are generally felt to be healthy fats. So for example, omega-3 fatty acids are all over the news. So these are things, for example, in salmon, in walnuts and flax seeds. So we do know that omega-3 fatty acids have been associated with decreased inflammation. So omega-6 fatty acids are also unsaturated fats, but interestingly, they have been associated with increased inflammation, okay? Omega-6 fatty acids are found in refined vegetable oils, okay? So way back in the day, before we became much more industrialized peoples, the balance of omega-3 to omega-6 was fairly even to maybe even more omega-3. As we have become more industrialized, we consume way more omega-6 than omega-3 now. We think that that balance may have a role here, okay? You all have probably heard about, yes? Canola oil. Mm-hmm. Exactly. Saturated fats are found predominantly in animals. So milk has saturated fats, steak has saturated fat, chicken has saturated fat. Okay, so this is just a background about fat here, guys. I have not concluded about this myth yet. So the conclusion about this is actually a myth. A diet high in healthy fats can actually be quite healthy and well balanced, okay? So a high fat diet in itself is not a bad thing, but finding the right balance of fats is important, okay? So nuts, seeds, salmon, avocado, those are all very good things, okay? And again, we think that if you're not eating a lot of fats, oftentimes that gets substituted with a lot of carbohydrates, and that's probably more problematic. So we think, again, this is all about a balance here. You need good fat, protein, and carbohydrates. Yes?
How about coconut oil?
So coconut oil, there's a lot of debate about sort of what is the role of coconut oil. So this has predominantly long-chain fatty acids, medium-chain fatty acids, and it has a lot of saturated fat in it. So Again, coconut oil in itself is not a bad thing, but I think finding the right balance here, you want to be mindful about the total amount of saturated fat that you're consuming. Saturated fat is associated with atherosclerosis and sort of cardiovascular disease. In terms of coconut oil specific effect on GI tract inflammation, I don't know of specific studies, but I do think that it's very reasonable to have coconut oil as part of your sort of healthy fat distribution. Okay? Yes?
What were the three things you said to balance good fat, protein, and
Carbohydrates as well too. So it has to be a balance here. If you focus only on one thing, you're going to put something else off kilter here. So again, this is a true myth number 6, okay? Myth number 7 is going to be difficult for you guys to answer. Myth number 7, Dr. Wabe, Dr. Suskin, Dr. Lee have offices all in a row, and if you broke down the walls, it'd be a single large office. Truth? Myth? Not sure. Okay. I put this in here because this is a truth, and this was the only truth out of all of the ones that we put in there. So that's why I had to put this one in. So the other ones were myths, okay, guys? So thank you. This is actually true. All right. We're going to next talk a little bit about dietary therapy for IBD, okay? We're going to talk about exclusive enteral nutrition, which I'm going to call EEN, and then we're going to talk about the specific carbohydrate diet. So, as you guys know, there are quite a few different strategies for treating inflammatory bowel disease. There is the 5-ASA classification, pentasa, mesalamine, azokal, Lialda, apriso, immunosuppressive medications, prednisone, azathioprine methotrexate. The biologics are Remicade and Humira, okay? And there are other biologics as well. And we also know about nutrition. We're going to talk about exclusive enteral nutrition and the specific carbohydrate diet. So, Dr. Suskin went in detail about immunosuppressive medications, and the conventional the existing sort of approach that the majority of GI doctors throughout the world will focus on is let's control the inflammation by suppressing the immune system, okay? Damping down the body's ability to react, okay? Unfortunately, this does not address some of the potential environmental triggers, okay? So that's why we think that diet's important. So I don't want to be sort of a person saying that the sky is falling, but immunosuppression does have small risk associated. And I'll tell you, greater than 90% of my patients are on immunosuppression and they need it, okay? And we talk about the risk of infection, maybe a little bit harder to fight off certain infections, increased risk of certain forms of cancer. It's a very small increased risk associated with immunosuppressive medications. And as you guys know, certain medications have specific side effects like liver irritation or white blood cell count abnormalities, okay? So immunosuppressive medications, they are absolutely an important part of the algorithm for treating inflammatory bowel disease, but they don't address environmental triggers, and there is a side effect profile. All right, so why do we, especially here at Seattle Children's, focus on food so much? So again, I've talked about dietary exposures are associated with IBD. Immigration studies suggest that if your parents were born in a country like somewhere in Africa where there was a very low incidence of IBD, when the parents from Africa move to the US, they don't take on the higher risk of developing IBD that we US people have, but their kids will take on that higher risk. Again, the genetics are not changing significantly from parents to kids, but the environment is. So that makes us be really suspicious about foods and environmental triggers. And then finally, we know that exclusion diets like EEN and SCD can be effective therapy for IBD. So we think that there's something about this Western diet that's problematic. And I define Western diet as high in dairy, high in cereals, high in refined sugars, high in refined vegetable oils, and processed foods is kind of this processed food thing, okay? So things that have a lot of sort of chemical ingredients and are in bags and can last for like 20 years if they're just kept on the shelf. All right, so we're going to talk about exclusive enteral nutrition first. Can I ask, have any families had intense discussions or tried exclusive enteral nutrition here? Okay, great. So you guys have experienced this. This is not easy, but this is the nutritional therapy that is the most rigorously studied for inflammatory bowel disease, okay? Not everybody as a GI doctor has heard about this or has practiced this, but this is the most well-studied nutritional therapy for IBD. In Canada and in Europe, it is very standard to use this as first-line therapy, whereas in the US, oftentimes it's not implemented quite as early on. It's also known as the defined formula diet, and it provides 90 to 100% of your daily calories buy a formula. Okay, so you drink formula, or you have a nasogastric tube and you get formula, and that's about it. We will allow drinking water, and there are discussions about should we allow some foods to be eaten as well too, okay? But as the name implies, exclusive, ideally this is 100% formula, 0% other foods, okay? So the history of nutrition in IBD, so EEN was first used back in the 1930s. So people that were very ill in surgical units that could not eat, they had an NG tube placed, and they had formula run, and interestingly, they got better. In the 1960s at the University of Pennsylvania, where I did some of my time, they developed parenteral nutrition, which is an IV modality of nutrition. That, interestingly, has not been shown as beneficial for inflammatory bowel disease. In 1973, a surgeon reported 13 patients with inflammatory bowel disease. They had severe stricturing disease, so those scars, so they really couldn't eat. But he treated them with the formula, and really interestingly, they gained weight, and their markers of inflammation got better, okay? And again, with EEN, so with the nasogastric tube formula, you don't need like a special IV that puts you at risk for infections and things like that, okay? So after this, there's been numerous studies looking at EEN as therapy, and we've actually even compared studies looking at EEN and steroids, and I'll show you one slide about a comparison. We know that prednisone is very good. If you compare EEN to prednisone, it's been very interesting to see how they stack up. All right, I'm going to do 3 questions about EEN. I'm going to go over, is EEN effective in both adults and children? Second, what formulas should be used for EEN? And third, what are some of the barriers for using EEN? Because in the United States, we as pediatric GI doctors, adult GI doctors, we do not use this as a frequent therapy. So I apologize, this is kind of a crazy slide, but the bottom line is, so there have been big review studies, and they have concluded that EEN is less effective than steroids, okay? The problem here, I'll say a major limitation, is they were looking mostly at adult studies, not pediatric, okay? In the greenish here I've highlighted, if you look at EEN in pediatric Crohn's disease, it is effective in 70 to 80%. So there's a disconnect here. Adult studies not looking effective, pediatric looking effective. All right, so why is it different in adults and children? So there was a recent review, this was in 2013, and it looked at EEN in adults. And how many of you in the audience as an adult could be on drinking formula only for 8 to 12 weeks and be a happy camper and do it like 100%? How many of you could do it? I think that's kind of very telling. I couldn't do it, I don't think either. So the studies showed that for adults on this therapy, there was very poor compliance. People complained about it tastes bad. I'm not motivated to do this. So again, they looked at outcomes, sort of improvement in inflammation in adults that weren't even doing the therapy well. So it was not effective, okay? The other piece, adults generally have had disease for a much longer period of time, and adults have generally been on many, many more medications leading up to being on EEN. So their immune system is a little bit different, okay? There were a couple really nice studies, and they looked at EEN in treatment-naive adults. That means adults who have not been on other medicines and who have a short duration since diagnosis. So they're kind of like kids who are starting a new therapy. So this is what it shows. These two studies, 1990 and 84, they show that the percent of adults achieving clinical remission, if they are treatment naive, it's like 82%. Okay, this is very similar to what the pediatric data suggests. So in my opinion, sort of EEN can be effective in adults. You have to be compliant with the therapy, and if you have a very long-standing history of disease, you may not have quite the same response, okay? So what formulas should be used for EEN? So bottom line here in orange, there is no significant differences in outcomes based upon formula composition. So the type of protein, the type of fat, the amount of carbohydrates, it doesn't seem to be a big difference. The considerations that your doctor will have is how does it taste and what is the osmotic load? So the osmotic load means how many particles are per certain volume of fluid. Certain formulas have a higher osmolarity, and they can be more likely to cause diarrhea. So these are sort of parameters that your doctor and your dietitian will discuss if your child is to start on EEN. I'm going to skip this for sake of time. So what are the barriers to using EEN? So this is kind of crazy when I look at it. In the United States, 4% of pediatric GI doctors use EEN on a regular basis. In Europe, 62% of doctors do. I would say this was a study in like 2011. This percentage in the United States is rising. So it's for sure is rising, and I think it's closer to like 15 to 20% right now. And a lot of it has to do with the GI doctors have not been trained to use this. So it's important that we as the doctors train the future upcoming next generation about the efficacy of this therapy. So to summarize, EEN effective in both adults and children. Formula type, it can be anything. Pediasure, Ensure, Boost, those are all fair game. And what are the barriers to using EEN? Numerous, but the physician being familiar and their perception about how good this therapy is very important. So this is a slide I mentioned before, comparison of EEN to steroids. And I want to turn your attention to the slide on the right side there, guys. This is repeat colonoscopy after having been on EEN for 10 weeks. And again, this shows that the folks on EEN had 70% healing of the GI tract mucosa, but for steroids it was only 30%. So this is suggesting that perhaps EEN is even more effective at steroids at healing the GI tract mucosa. Kathleen told me I had 4 minutes, so I'm going to jump to the SCD, okay? And we're going to give you guys all copies of these slides, so you'll have a little bit of additional reading material. So EEN and table foods. So EEN is not a therapy that you use like long-term in general, okay? It's difficult, so we'll use it for 8 to 12 weeks and then gradually transition to eating foods. So we can transition either to being on medications or a whole foods-based diet. And we know that certain foods seem to be associated with decrease in intestinal inflammation, and that's where these whole food-based restriction diets come in. So here's a list of different elimination diets that have been studied and a list of specific foods that have been studied as well too. I'm going to focus on the specific carbohydrate diet, as this is probably the most promising of these elimination diets right now, and this is what we have some data on at Seattle Children's Hospital. Bottom line for these restriction diets, elimination diets, and specific foods, there is more data that is needed. Okay, there's not a definitive, this for sure is the best therapy to use versus not. For EEN, there is definitive data. For these, we need to generate definitive data. All right, I'm going to talk a little bit about the specific carbohydrate diet. So this diet limits all grains, so again, this is wheat, rice, oats, corn, all grains, all refined sugars, cow's milk products, except for certain hard cheeses and yogurt that's been fermented for 24 hours, and also in general, broadly, it eliminates processed foods. So there are a lot of people out in the world that have tried this as therapy, and people talk about how it's very beneficial. We as a GI doctor community, we think it's important really to make sure that the markers of inflammation are coming down. We want symptoms to improve, yes, but very critical that inflammation gets better. Sorry, I'll be 3 minutes. Okay, here's a list of some studies on the specific carbohydrate diet. The first, third, and fourth have all been Seattle Children's involved studies, okay? And the second one is a study in adults. All of these show that there is some benefit to the specific carbohydrate diet. Column number 3 is N, which is the number of people in this study. So these are smaller studies here, guys. Many big drug trials are hundreds of people. These are sort of in the double digits and even single digits, so we need bigger trials to assess for this. Okay, this is a paper that Dr. Suskin's team, and I'm part of that, we published, and this is looking at 26 kids, some with UC, some with Crohn's. On the left here, we see clinical disease activity, and this is going over time from at baseline to over 12 months. You see that in general, there's a trend towards improvement. On the right side, we see a graph looking at ESR, which is a marker of inflammation. We see that over time, ESR does come down as well too. We feel very strongly that you have to look at objective markers of inflammation like ESR, CRP. All right, this is a fun little study that Dr. Susskind and I did. We did an online survey. There was 417 respondents, and people described their improvements in symptoms over time. So all of the different bars are symptoms, and then going from left to right, it's chronology from baseline starting SCD to 12 months. As you can see, all of these symptoms, people say, gradually improve over the 12 months. So I think this is great, very promising, but again, we have to study markers of inflammation in addition to these symptoms. All right, you guys have probably met Kim Brawley and some of our other dietitians. This is a wonderful paper that they published, and this is really looking at kids on the SCD and another sort of national cohort of children and looking at sort of nutritional adequacy on the specific carbohydrate diet. Interestingly, if you look towards the regular kids on the right, there are many kids. This is percentage of kids meeting dietary recommendations for these vitamins and minerals. There's a lot of things that we don't do a very good job. So calcium is not very good for the healthy kids on the right. In the kids with SCD, it's also problematic as well too. So the takeaway from this slide, SCD is very comparable to other healthy populations in terms of nutritional adequacy. Because of things like the worry about calcium deficiency, we do have to follow and make sure that we are assessing your child's dietary status and intake carefully. So you got to follow with a doc and a dietitian. All right, last couple slides. Upcoming exciting SCD studies. There's a multi-center study led by Dr. David Suskind. There's going to be 120 kids with active Crohn's disease. They'll be followed over 32 weeks. What's going to happen is they'll be on the SCD, then they'll add in certain foods. Then they'll take out that certain food and then add it back in. We're going to look for changes that occur with changes in the diet, okay? So for example, if you're on the SCD and doing very well, excellent. If you add in corn and you're more problematic, that is suggesting that certain foods are more problematic. So we're excited to learn about SCD and specific foods on this study. The next study is an adult study. Dr. James Lewis is at the University of Pennsylvania. He's one of my mentors. This is a great study. They're going to compare SCD to the Mediterranean diet. 194 people, they're going to have 2 arms. They're going to deliver you food, so I would totally volunteer for this. 3 meals, 2 snacks, and it's going to be over, how long is this? 6 weeks, so it's great. And they're going to assess disease activity, fecal calprotectin. So great adult study, and I think we need adults to study stuff like this too. This is a good example of us as a pediatric community putting forth this idea, and now the adults are following along. All right, couple resources. So the nimble.org website is something that Dr. Suskind has spearheaded. If you have not checked it out, this is a cool website both to learn about inflammatory bowel disease and also there's some funny videos with me and Dr. Suskind and Dr. Wabe. We're very embarrassed. But we talk about diet, disease, and there's also information about how do I succeed with this specific carbohydrate diet. There's some families that also discuss this. There's a really cool SCD kids cooking group as well too. So if you're interested, please contact your doc or the nurse. A group of kids, and in particular one patient, Avi Shapiro, he's spearheaded a group where kids will come together and they will kind of converse, have a time to discuss how they're doing and really learn how to make some cool SCD foods. So feel free to contact your doctor if you're interested in getting your kid involved. Conclusion, disease location can explain symptoms and it can guide therapy. Second, there are many myths out there about IBD and diet. Third, dietary therapy can be effective, but it's not for everybody. Importantly, you've got to partner with your doctor and dietitian for nutritional therapy. It's not something that can be successful on your own. Thank you, guys.